Dr. Mike Bevilacqua is a nephrologist with additional training in health administration. His clinical nephrology practice is based in Surrey, British Columbia, and he is involved in several administrative roles with BC Renal. He is the chair of the Provincial Kidney Care Committee, which coordinates care delivery for over 15,000 British Columbians living with chronic kidney disease, and the medical lead for the BC Polycystic Kidney Disease Network, which aims to optimize management of PKD in BC, and he's also the co-chair of the Transplant First Committee, aiming to improve access to living donor kidney transplantation. So even as busy as he is, Dr. Mike is always willing to support the foundation and the community. We're very grateful to have him here again tonight. So without further ado, Dr. Bevilacqua.
Great, thanks so much.
All yours.
Get the clicker.
There you go.
Without this, we'll just be looking at the title slide for a really long time. Great, yeah, I couldn't say more, just like Jeff did. Thanks everyone for coming. It's great to be able to do this in person. You know, we have had webinars before, but this allows for a little bit more interactivity. We have slides and some sections we'll go through. I do want to encourage some discussion though and questions. So there's a few points where we'll naturally break for our questions, but if things come up along the way that need clarification, go ahead, just pop your hand up, and if I see it, we'll try to address it. So don't be shy to ask questions and have some discussion along the way. Right before we get started, it's good to have a couple of disclosures. I do have some financial disclosures with pharmaceutical groups, including the one that manufactures tolvaptan for the treatment of polycystic disease. To mitigate that, I'll only be discussing published data. I won't be talking about trade names or anything like that. So the agenda today is basically all of polycystic kidney disease in about an hour or an hour and a half. So it's a big, big topic, but we're going to try and work through it. And we've kind of broken it down into a few categories, thinking to almost mirror what someone's journey with the disease might look like. So first of all, what does it mean to be diagnosed? How do we make the diagnosis? What does it mean for you and your family? How do we live well? And put into that, there's a whole host of different considerations. What are the various treatment options? And then we have at the end, because it often does come up, what might we have to do if the kidneys aren't able to work properly. As time goes along, we'll see if we get to that one. The other ones being, I think, much more specific to PKD, but we'll try to cover the whole gamut here. So to start, it's always just worth a little refresher to start from square one of what do your kidneys do. So your kidneys are these little organs that, a normal kidney is about the size of your fist, sits under your rib cage, and think of them as being the filters that clean out your blood. And they do so at a really, really impressive rate. I like showing those numbers because people are always surprised by that, saying they filter 200 liters a day. They're just always churning through your bloodstream there. And they're able to filter out the waste. They also have a few other very important roles, a lot of hormone regulation. They control a lot of things like blood pressure and what we call bone mineral metabolism, and a few other hormone systems in your body as well. So very important organs. Now, when we talk about polycystic kidney disease, and when I say PKD today, I'm mainly going to be talking about autosomal dominant polycystic kidney disease there, although there are similarities. What we're talking about is this is a genetic condition, meaning that it's something that someone is born with. It's in the cells of their body even before they're born and as they're forming. And it's actually quite a common one. When we talk about a genetic condition that affects somewhere between 1 in 500 to 1 in 1,000 patients, as far as genetic conditions go, that's actually quite common. So if we'll talk about BC, we're thinking of north of 10,000 people living with polycystic kidney disease. You know, so quite large numbers out there. So it's a gene change. It's a gene change that for one of several different proteins, which we'll talk about in a second. But what happens, we talked about the normal kidney being the filtering job, or the filtering unit, is that these kidneys start to develop cysts. Now, these cysts, think of them as little bubbles. When people hear the word cyst, often with a lot of other things, they think, you know, is this a tumor or something like that? Think less of a tumor, think more bubble wrap. So like a little pocket that's full of fluid. That's what we're talking about when we mean cyst here. And if we just pulled people off the street, depending on their age, up to about 20 to even 25% of people might have 1 or 2 cysts in their kidneys. But here we're talking about lots of cysts. The name polycystic just means many cysts. So what happens is these kidneys develop cysts. It's still in a minority of the filtering units of the kidney. Each kidney has several 100,000, if not 1 million of these filtering units. And we're talking about a minority, maybe on the order of a few hundred, up to maybe 1,000 or so, that develop these pockets. And what happens is as time goes on, you tend to get more of these. So more of these bubbles are forming. And the cysts that are already there tend to get bigger as well. So more cysts, bigger cysts. And eventually, what you can see happening here, these little pockets being the cysts, it's a little bit more complicated than this, but think of it as essentially they start to squeeze out that healthy kidney tissue, that brown stuff here, and so that it's not able to really do its job anymore. So even though it's only a minority of the part of the kidney, it ultimately impacts the rest of the function of it. And we'll talk about that as we go on. So, oh, right, and I kind of went through this here, and this is a nice little picture that kind of shows that just a few of these might develop from the filtering units. I'm going to move this just a bit because since I have to turn my head to see the slides, I want to make sure you can still hear me. There we go. Yeah, and then they can kind of pop up anywhere along and filled with fluid, and time goes on, you accumulate more. So early in the disease, as we're talking about how are we going to pick up polycystic kidney disease, there are a few things that we might see, but I'm actually going to start on this bottom line. Actually, in a lot of people, especially when we're talking very early, the most common symptom is going to be nothing. So if someone's in their young childhood or even early adulthood, they might not notice a thing. There might be no symptoms whatsoever. Some of the things that we see that can be clues of it is high blood pressure, and specifically high blood pressure at a young age. It's common for people to have high blood pressure later in life. When it happens early in life, we always need to think as physicians of what's causing that. This is one of the reasons. There are some more obvious things like blood in the urine. That can be very dramatic. So that's not a subtle thing. People would notice if that happens. Some people and one of the common reasons, one of the most common symptoms that people might actually get is just some general abdominal, some kind of discomfort around their middle, and then ultimately someone does a test and then finds it. So that's a very common one. And then some of these complications related to the kidneys as well, things like stones or infections. It could be some of these, it could be none of these, it could be all of these. It's very variable. So relying just on symptoms doesn't necessarily tell us, but these are some of the ways that the disease might be first thought of. As time goes on, then things will start to appear. So again, as I said at the beginning, being a genetic disease, it's something that starts even before you're born and is kind of carrying on as you develop, and then it carries on through the course of people's life. It's a lifelong condition that progresses as time goes on. So as time goes on, you might start to notice more things. As those kidneys start to get more and more cysts and the cysts get bigger, the kidneys actually get bigger, and so people can start to have symptoms related to just the size of the organs in there. Ultimately, we might see the kidney function start to go down, and we'll talk about that a lot more in a little bit here. And then we might see some symptoms related to various other complications. We'll come to that part as well, where people can have cysts in other organs, a big one being the liver. You heard Jeff talk about his family's experience with that. That definitely is a big source of this. But there are other few places in the body that this might come up as well. So I really like this picture, which I kind of look at as PKD in a nutshell. So this is the whole life experience of polycystic kidney disease. So let's go through this, in a little bit of detail. So here we have the kidney, and you can see that nice brown stuff in the middle. That's the healthy kidney tissue, and those little bubbles are the cysts. So this is meant to be as the time goes on, and you see that what's happening is this kidney is developing more cysts. The cysts are getting bigger. The kidneys themselves actually start to get larger because they physically expand to accommodate those cysts. And then as we talked about, you lose that healthy kidney tissue. These pictures are showing the blood vessels, which actually change. You lose some of the healthy blood vessel. But one of the big things that I want to show is this red line here that we talk about for kidney function, called GFR. That's one of the common tests we use to assess it. For much of the condition, it's actually totally normal, totally stable. It's not until you lose a lot of that healthy kidney tissue that you start to actually see a change there. The flip side of this is that if someone's just looking at your kidney function and waiting for that to change, by the time it does change, you've missed most of the action. Most of the disease has already happened by the time you start to see the kidney function change. There's a lot that happens before you would ever notice a change in GFR, and we're going to talk about some ways that we actually assess that. Very specifically, what I don't have here is time. And what I mean by that is this can unfold at very different speeds for different people. It can range from everything from somebody needing kidney replacement treatments or at a very young age. I have some patients that are in their 20s and I'm getting them ready for a transplant. And then you hear other people, we hear Jeff talk about that, and I definitely have other people who have that experience who live into their mid-80s, 90, and yeah, maybe their kidney function has gone down, but they've never needed dialysis or a transplant and they pass away from something else. So it can be from kidney failure at a young age to never kidney failure and literally everything in between. And we'll talk about ways in a little bit about how we predict where might each individual fall, because that's obviously a really wide range that we're talking about. So before we get to predicting that, we'll just talk about the diagnosis itself. So obviously there's a few ways we can pick it up. One is if you come from a family where you know multiple people have had this. We'll talk about the inheritance in a second, but you'll know there's a high chance you might have the condition and then go out to be tested. But about 25% of people who we meet with polycystic disease have never heard of anybody else in their family having this. And this is a pretty standard number kind of worldwide. So a quarter of people, this is not the same for other genetic conditions. Most of the time with a genetic condition, people know it's running in the family. But with this one, it's actually quite common, mainly because of the fact that it can kind of be a silent one, right? Some people have no symptoms, they kind of fly under the radar. So there might be people that the family wasn't diagnosed. And there's a whole group of people that when we talk about the genes for it, that truly will be the first one to have that mutation. So someone has to be the first one to have it, and that's more common with this than some other genetic diseases. So in some people, there are no family histories, so then we need to look a little bit more. When we're trying to make a diagnosis, our first step is always with imaging tests. So ultrasound being, by far the most common one. Last time we went and surveyed Canadian nephrologists, something like 95% ultrasound is the first test to look for and diagnose polycystic disease, and we can pick it up quite well. So this ultrasound, it's not a baby, this is a kidney, and those bubbles that have the C in there, those are the cysts. So you can actually pick it up quite well with that. Sometimes we'll go to more advanced imaging tests like a CT or an MRI. And then in some occasions, although honestly it's the minority as of right now, we might actually use genetic testing. It sounds odd to say that genetic testing is the minority in a genetic disease, but the reason for that is that actually most of the information we need we can get from these much simpler imaging tests, and genetics often doesn't add a whole lot more to that. But there are some cases where we'll use a genetic test to diagnose. So the genetics, when we talk about it, this slide has changed over the years, right? When we first started doing this, when I went to medical school and through my training, they would say that PKD was caused by one of two genes. I've added this part at the beginning now where we say most commonly. We're now up to almost a dozen genes that are identified, and that list keeps growing. Before we used to just look for these two called PKD1 and PKD2, and we'd say about somewhere between 10, maybe 15% had no genetic diagnosis. We're actually learning what a lot of those are. Even as that expands, there's still a small subgroup that we haven't found. I'm still going to talk mostly about these ones because all those other genes that we found, most of them make up for less than 1% of people with PKD. So still by and away, these are the most common. Now, these are the general ways that we talk about this. And you'll see in the next slide that it doesn't always follow this rule. But, oh, yes.
I have a question about, sorry to interrupt,
No,
on the
Chris.
previous slide.
Okay.
For
Oh, there we go. Yeah.
is a renal biopsy already given?
No, and actually we wouldn't tend to do a biopsy just because when there's a lot of cysts there actually, so biopsy means putting a needle in to actually take a sample and do some looking under the microscope, do some tests. When there's a lot of cysts there, you might actually cause some damage. And because of the fact that the imaging is so good, this is why we can use it in the vast majority of times. And as time goes on, the imaging has just gotten better and better and better. So our ability to pick it up with that is just is very, very good. Yeah. But yeah, it's a very good question. Yes, so back to the genetics, we'll talk about in general, you talk about these two things, PKD1 and PKD2 representing one of the two major genes that is represented. PKD1 is the more common one, and the reason for that is it's just a gene that's more prone to mutation, just the way it's set up, it's prone to having these changes in it. And it's the majority of it. We generally think of PKD1 as being faster, more aggressive decline in kidney function. Although again, I'll show in a second that doesn't hold for everyone, whereas PKD2 tends to be a slower type of a condition. We tend to think of having it as more complications. But there can be a huge amount of variation in this. And I think I have it on this next slide, yeah. This is a really good example of what I mean by the variation. So although we might say, yes, general genes track together, there's a lot of difference here. So this is kind of a cool slide. This is from Matt Langtree, who's going to be talking at that PKD summit that Jeff was talking about. So to walk you through it, each one of these vertical lines is a family, meaning that everybody in that family has the same gene causing polycystic disease. But what these dots are is it shows when did they actually go on to have kidney failure, need transplant or dialysis or things like that. And you can see that even in some of these families that remember, they all share the same gene, you can see a really wide spread. Like this one, you have somebody reaching kidney failure at 40 and another person at 95, right? That's a 55-year spread in how people have done. So the gene itself doesn't tell you the whole story. There are a whole lot of other factors that play into it. So the old teaching of kind of PKD1, fast and rapid, PKD2, slow and kind of more indolent, that doesn't necessarily always hold. We definitely see people, as you can see here, with PKD2 who will reach complications at an early age. We definitely see people with PKD1 who will make it quite late in life before they need kidney replacement treatment. So as we learn more about the disease, we're learning that it's really a spectrum rather than just two different sides of a coin. We'll talk more in a little bit about how we predict exactly what's going to happen. But while we're on the genetic and diagnosis part, I think it's worth saying, okay, so we've talked about the how someone makes a diagnosis. I can say almost always the first question that comes up when people have children and I'm meeting them for the first time and giving them their diagnosis, the first question they ask is, what does this mean for my family? What does this mean for my kids? And what are the chances this might pass on? So the AD part, in AD-PKD, autosomal dominant, that talks about how it's inherited. And what it means is that when somebody has polycystic disease, there's a 50% chance that they'll pass it on to each one of their kids. So it's literally a flip of a coin as to whether one kid will have it or not. If that child has it, it's then a 50% chance that they'll pass it on to their children. If they don't have it, then that's it. That branch of the family tree, it stops. It's not one of these things you hear about people skipping a generation or something like that. It's not that type of condition. So with AD-PKD, if the kid doesn't have it, they can go on, they'll have their children, they don't have to worry about it. Whereas if they do, it starts over again, 50-50 chance with each one. It's entirely due to chance. And it's sometimes, with statistics, you sometimes see things like I've definitely met families where they say, well, all the boys have PKD and all the girls are fine. That's just kind of a, statistical luck of the draw type of a thing. It's not like, male or female or any other thing is specifically driving it. It's 50-50 chance for each kid. So we've talked about when an individual was diagnosed and picked up with a test, but this is always the next question that we have is, when should people be screened? So the difference between testing and screening is testing is when you have an individual in front of you who's showing some signs and you want to do some tests and say, okay, I think there's something going on here, I'm going to test them. Screening is now talking about we have people in the family who otherwise are feeling well. Should we go around and test them to look for the condition? And there's kind of pros and cons to both. It's something that I talk through with all of my patients. Obviously, so there's some advantages, things like knowing about it early. You might be able to implement some treatments earlier. You might be able to make some lifestyle changes. There's a whole lot of things that as treatments evolve, somebody will already be known and will be in the radar so that we can kind of implement new things as they come. So there's a lot of advantages to it. It is worth remembering, though, that there are some downsides, especially when we talk about children. We'll talk about in a second that just going for tests all the time and having to have a lot of interventions done does kind of add to things. Some people just kind of don't want that weighing on them. I've definitely met a lot of people who have said, well, I'm otherwise feeling well. Do I really need this hanging over my head right now? Maybe I'll look at this later in life, but right now it's not going to change how I live my life, so I'm going to go do my thing, and that's a totally reasonable thing to say as well. There unfortunately can be, this question always comes up, things about life insurance. There unfortunately can be some considerations there. Now, what I often tell my patients is that I wouldn't necessarily make that your deciding factor, because when it comes to insurance, if you already know about this, you're kind of going to get flagged anyways. And what I mean by that is, any insurance intake is going to ask you about family background. And if you say, oh, there's kidney disease in the family, and they'll say, well, what kind of kidney disease? And you say polycystic kidney disease, the insurance companies know what that means. So you're going to get flagged regardless. So that's why I say it's almost you hate to say it, but either way, the insurance companies are going to get you. That's what they do. So, don't make a decision just based on that is usually my advice. But there are very real concerns around things like employment, right? Oh, does my employer going to know, or what's going to happen if people find out that I have this? So there are considerations, reasons you might not get tested. So if we decide to talk about this in our family, the way they would get tested, though, is they would use the same ones we talked about for the first diagnosis. So imaging is actually the first test. And actually, when someone comes from a family where they know there's PKD, the imaging tests like ultrasound and things like that, we're actually even better able to pick it up because you kind of know what you're looking for, and you're going in already with a high probability of the condition. So the tests are even stronger in that situation. We sometimes might do genetic testing. One of the situations where it's helpful is if one person's had a genetic test, the way the testing works is it actually makes it much easier for related family members to look for it, because rather than looking for any gene, you're looking for one specific one. If this is a consideration you're thinking about, most of the places that offer the genetic testing, they do that in a time-limited way. And what I mean by that is if, say, I'm going to go get a genetic test done, they would say, well, my whole family could go within 6 months, and they'll do it free of cost because it's actually quite easy for them to do that, whereas afterwards it's a little bit trickier. So I just always put that plug out that if someone's offered you to do genetic testing, that's a good time to actually say, hey, does anybody else want this at the same time? Because if there's a positive result, they can do it pretty easily. But again, this is something, in general, what I would say is if there's any specific considerations, if you have family members who say if you have the diagnosis, they're not sure what they should do, have them just come in and talk with their physician, and they can take them through the pros and cons of it. I specifically, right, okay, I have another slide there about children. What I would say is that if somebody comes from a family with known polycystic disease and they choose not to be tested, which again can be a quite reasonable choice in a lot of situations, they still want to do a few things. They should still be going for regular checkups that specifically include blood pressure monitoring. High blood pressure is often one of the earliest signs. And so, for example, if say, I've got a brother who's got polycystic disease and I'm going to get my blood pressure checked and I'm 30 years old and my blood pressure is high, that should automatically kind of start putting alarm bells off that, okay, now all of a sudden we should be looking because we're starting to see a sign for it. Obviously, some blood and urine tests, and then if any symptoms come up, like those things we talked about, like pain, blood in the urine, these are quite obvious reasons that, okay, now we need to go ahead and test that person. So if they're not being tested, they still want to kind of keep in the system because we don't want to ignore it, and then all of a sudden somebody shows up at 60 years old and most of the process has already happened, and we can't go back in time and fix anything, right? So they want to, even if they're not testing, just kind of keep on the radar there. This is the one that I wanted to go into a specific detail just for a quick minute, and we've got some great resources on the website there, and when I say on the website, they're on all of our websites. We were fortunate enough, us at BC Renal, to work with the PKD Foundation and the Kidney Foundation. That's why all of our logos are on these things. They're available on all of our websites that specifically talk through this process of testing. For children, there's some kind of additional considerations there. Maybe I'll mention for a couple of minutes now because it's always people's first question. The general rule of thumb is that we don't necessarily need to test asymptomatic children early in life. And by asymptomatic, what I mean is there's two big things going on. One is that they have normal blood pressure, and the other is that they don't have any obvious symptoms, things like those infections or blood in the urine or abdominal pain or things like that. If those two things are met, and the normal blood pressure, I emphasize that because if you're electing this route with one of your children, nobody ever checks children's blood pressure. So I actually specifically put in my notes back to the family doctor to say, check their blood pressure at their annual checkups, make sure they're not having any symptoms. If they're asymptomatic and have normal blood pressure, generally we say you can wait even until the late teens or early 20s for them to be tested, because earlier on it's probably not going to change what we do. And that's often one of the big driving points to say, should I do testing, is are you going to do anything different with the result? And again, this is an individual situation, but I can definitely say that I've had families where the child gets tested early in life, And then what ends up happening is every year that child goes for ultrasounds and blood tests and goes to appointments and you know, there's a lot of activity that's involved with it, but it doesn't actually change what we're doing as of right now. And just doing all that testing does kind of put the child through something, right? So that's why in general we say you can wait until that time. And the nice thing then is now all of a sudden, rather than a child, we're talking about a young adult that you can actually talk to, and they can be involved in that decision about, do I want to get tested or not? So that's kind of the general guidance, and you'll see that's what all of the various guidelines would tell you. Again, individualized, but that's the route that most people end up going. It might change in the future. If we all of a sudden start having treatments that would be effective in children at a young age, then that might change. But the main reason that we don't do that now is because we wouldn't change any of the treatments. Finally, when you go on to get diagnosed, oh yes, please. That's a great question, and the answer is not absolute. Yeah, so, and that's another reason that actually sometimes we don't do the testing early on is because, you know, when we showed that first slide, we showed those little cysts as being very small. They actually do start off as microscopic. If you do an ultrasound too early, it might be that the cysts are there, but they're too small and you can't actually see them. And that 18 to 19-year-old, usually we might see things by then, but say if they had a slower form of the condition, you definitely could miss it with an ultrasound. So a lot of those families, we would tell them, well, if you've had one at 18 or 19 and it's negative, I actually suggest to people, and this is what most of the guidelines would say too, is, oh, go on and repeat it again. You know, some years from now, give it a little bit more time. And as the more time goes on, the more certain we are. Yes. So there are sometimes situations, that is excellent questions. And, oh, sorry, maybe people couldn't hear it. The other question then would the genetic testing be? No genetic testing is 100%, but what I should say is it's not subject to that age factor. It's just as accurate in children as it would be later in life. So this is actually one of the situations where we sometimes will do genetic testing actually, is that someone comes from a family, they're very young and we need to know. Yeah, absolutely. That's one of the situations we do. That's a very good question. Right, as we go on, and then so coming back to this, say you're diagnosed, you'll have a whole team wrapped around you. It can involve some, all, or some combination of these people. Your family doctor always being kind of the cornerstone, various specialists, us kidney specialists, you might be other people involved depending on other things, and the whole rest of your team. And then I love this slide because it talks about your support system as first, right? And especially this more than other kidney diseases. We say this with every kidney disease, but I think it's especially true with polycystic disease. This is a disease that affects families, not individuals, right? So having a whole support network around you, I think is a great thing, and definitely one of the great roles of the PKD Foundation. So to summarize, this is still on the PKD website. The logo's changed. I got to update the slide, I guess. You know, we have a whole lot. One of the great things I love about the website is various videos and testimonials. Just you can take a look through there. If this is new to you, you know, see what other people who have actually been through this say as well. So I've got a few things there. Those are just almost prompts if people have questions, but maybe I'll pause there. This is a whole section about, okay, you've just learned about the condition. Are there any other questions that people have right now before we move on and talk a little bit more about how we actually assess and go on with the disease? Oh, yeah. And Jeff is going to circulate. He's going to be Phil Donahue here going around the room. I'm maybe dating myself by saying that.
Are the cysts inside or on the outside of the kidneys?
Yes. What I mean by that is all of the above. Yeah, exactly. So they can be distributed right throughout. So some are right deep down on the inside, some are sitting right on the outside, almost like a little pocket, and everything in between. So kind of throughout the whole kidney. Yeah.
And sort of an expansion of that, how common are the symptoms and the actual what the person is facing?
Yeah.
If I could just expand a little bit, you talked about tiny cysts. Mine apparently are the size of grapefruit and oranges, and my whole cavity is full. Does it vary all over?
Yeah, it does. So a couple of things to pick up on there. So in terms of the symptoms, we're going to talk a little bit more about that in more detail. So I'm going to pause that a bit aside to say that's another one that's almost like flipping a coin, right? So in other words, the rule of some of the data would say that by the time someone's in their 40s to 50s, about 50% of people with polycystic disease have had some symptom, which means the other 50% have had nothing. They had no idea, even up into 4 to 5 decades into this. So it is quite variable individual to individual. The cyst, it's an interesting thing without getting too much into the weeds here. There are this is one of the two patterns we sometimes see, and sometimes a bit different between PKD2 and PKD1, where PKD2 we often think of, again, this is a generalization, we often think of as being fewer but really big cysts, whereas PKD1 we often think of as being smaller but much more cysts. And those can be different in the way that they present with the symptoms of any one big giant cyst. But again, there's a lot of overlap between the two. But you're exactly right. Some of those symptoms, and we'll talk about this later, come down to exactly where does that cyst just happen to be? And that's essentially a random, thing as to where it might come up. Great. Oh, yes.
Sorry, I don't know if you were going to address all these, but does PKD, will it limit people's lifestyle in terms of the activities they can do, the sports they can do? And I don't mean sort of, when they're, on dialysis and things
Yeah.
like that, but in the years before, your graph, you said kidney function, like they do have cysts, but kidney function is still pretty regular?
Yeah, not particularly. And yeah, just to maybe I should say how we're going through this. I put these as prompts if people have any of these questions. We won't necessarily go through each of these, but these are just kind of some discussion points if people want to ask them. Yeah, the short answer, and we'll talk about this a little bit more, is no, I don't tend to limit a whole lot of activity with people. People are often worried about cyst rupture, which I think we'll talk about in a second, where the cyst can actually pop. Outside of real high impact things, like for example, I've had rugby players, lacrosse players in my practice. That's where I really talk to them about it, and actually have had to send some things to get people cleared to play and stuff like that. But outside of that, not necessarily. It's possible for something to pop, for one of these cysts to rupture, and we'll talk about that later, but sometimes it might happen with a small amount of activity. I often tell people that if it was going to say you're going for a jog and a cyst ruptures, that cyst was going to rupture anyways. If that amount of impact caused it to do it, it was kind of going to happen at some point regardless. So the short answer is no, and actually we know with all kinds of kidney disease, staying active is a very important thing, so we definitely encourage that.
This is not really a question, but I think something you should talk about, because it was always a question I had when I came to these, was the genetic testing and the ability for women to get IVF through that genetic testing. So maybe, I don't know if you want to talk about that, but.
Yeah, thank you. That's a really good point. So there is an option available that if people have a genetic diagnosis, that there is something that they can do, what we call PGD, pre-implantation genetic diagnosis. So through in vitro fertilization, there is a method where people could actually select essentially for an embryo that does not have the condition. So thanks for bringing this up. My general advice when I talk to people who are thinking about having kids, they've got PKD, is to say first think, would knowing that change what you're going to do with the pregnancy? And I'd say actually more than half the people I say no, I'm here, my parents had me the natural way, that's what we've decided we're going to go ahead and do, and they carry on and go about their way. And so if that's the case, then we don't go down the road of doing all these tests, because again, if it's not going to change what you're doing, we don't do it. But for the people who are thinking about that, there are groups that we can set them up where they could do exactly this. It is one of the reasons we do genetic testing. Now, the only unfortunate thing is, at least as of right now, I say as of right now because a lot of us really hope this is going to change soon. As of right now in BC, they're not paying for it for this reason. So it's something you would have to pay for out of pocket, which I think is just, we're recording this. I don't know if someone in the BC government is going to come after me, but let them, because I think that's just criminal. Other provinces do pay for this. I hope that'll change one day. But, for somebody who would want to do that and has the means to do so, it is definitely an option. So what we'll often do is if someone's going to go down that road, the first step is they'll meet what's called a genetic counselor to kind of take them through what do those various options look like. But yeah, thank you. It's a very good question. That definitely is available to people. Yeah. Yeah, thanks for that feedback. That's wonderful. And yeah, I'd say even after doing that again, when I send people over, sometimes about half, I'm just making up the numbers from what I remember offhand, but probably about half of them say, you know what, we talked to them, I'm not going to do this, but then at least you have all the information and you've heard it from that genetics counselor, right? So yeah, it's definitely, that part is covered, is to meet the genetics counselors. It's unfortunately the testing and the actual IVF process, as of right now, is not covered.
And if I can just interject for a minute, npkd.ca, our website, does have a webinar from a past summit on pre-implantation genetic diagnosis. So if anyone is looking for that information, it's on our website as well as our YouTube channel for the whole kit and caboodle.
Perfect. See, it all comes back to the website. We'll just keep plugging it all night long.
Shameless plug.
Yeah. That's a great question. I'm glad that came up. Okay, otherwise, so yeah, let's get into the next section. This kind of alluded to by some of the questions here, is living with PKD, and this is definitely the way we like to term it, right? This is a lifelong thing. You got to live your life. So how do we go about doing that well? So a lot of these, when we talk about how do I live well with PKD, actually these are just general good lifestyle things anyways, and some of these are general good kidney health things anyways. Things like maintaining a healthy weight, exercising regularly. We'll talk about the weight actually in a second. Avoiding smoking. You can see most of these are specific to, or general to anything. The ones that are a little bit more specific is keeping yourself well hydrated. And we'll talk about that a little bit more in just a second. Avoiding drugs that can be hard on your kidneys, making sure you're on top of your blood pressure. So these are kind of general, what we call motherhood statements, so general healthy lifestyle things. I don't think there's any surprises there. What I want to get into a little bit more, because this is after asking about, children and genetics, I'd say this is number 2 most common question, is what should I be doing with my diet? And it's great that there's actually been a lot of research coming out about this lately. So one of the nice things, big ticket items, is that you want just a general healthy diet, and we're shifting this way for a lot of kidney diseases, in that before we used to talk about, well, you have to limit this and phosphate and protein and all these various things. Whereas now, as the literature and the evidence have evolved, a lot of it is basically coming down to have a balanced diet and avoid highly processed foods. That's probably the most bang for your buck you can do with just about anything. But then there are a few specific things that we can talk about. And I'll show it actually in a little bit more detail in the next slide too. But maintaining a healthy weight, in addition to being good just for your general health, also specifically helps slow down the process of polycystic disease. So carrying extra weight actually accelerates the process. So keeping a healthy weight actually helps to slow that down. And then we're going to talk in a little bit more detail. I'm going to kind of maybe not read all these items out because I'm going to show you the next slide, which shows it in a visual format. But if you do that and avoid highly processed foods, I'd say that's 90% of the battle. Salt, everyone's aware of that. Why I say that this was 90% of the value is we know that in Canada, 90% of our salt comes from what's already in the food, mainly what's coming in processed and prepackaged foods. So you get 2 birds with 1 stone if you're avoiding a lot of processed stuff, as you're both getting healthier stuff, you're avoiding all those additives, some of which are hard on the kidney, and you're getting most of your salt. Whatever you add while you're cooking or at the table is on the order of 10% of the salt in your diet. It's all that hidden salt that's already in the foods. So that's why with that one item, actually you eliminate a whole bunch of different bad things. And then I'm going to talk, there's actually another slide I'm going to show that summarizes this nicely. Why I didn't have this on the slides is this is, oh sorry, that's too small to project, but this is hot off the press, as in this was literally published about 2 weeks ago. This is from Fouad Shabib's group over at the Mayo Clinic, where he actually summarized all of the data we have available for the different dietary strategies we have in polycystic disease. So this is fantastic, and I love this is the way that research is heading, where we're getting a lot of patient-led and patient-focused research, where people are asking this question, could you actually tell me what's the evidence behind these various diet changes? And I love that, I see people taking pictures. This will be posted and people can get the slides after. That's correct, Jeff? Yeah, okay. So yeah, don't feel the need that you gotta take pictures and everything, just we'll send this all to you. We'll send you the slides. You can look at it all yourself. That's why I put a lot of words on there so you can read it through later if you like. But they broke it into a few different categories, and I love this. So they talk about if you're carrying a bit of extra weight, you want to maintain a healthy weight, and you want to try to, if you're carrying a bit of extra weight, you do that by losing weight by being what we call a caloric deficit. So actually, essentially taking less calories in than you need. This is one of the few things that actually was proven to slow PKD in animal models. If you put mice, for example, on what we call a starvation diet, they never develop cysts. The problem is you can't really put humans on a starvation diet. They tend to not like that, and they tend to do things like die. So we can't go quite that extreme. But what this means is that if you're carrying extra weight, that caloric deficit actually will also help slow the condition, and getting down to that healthy weight will help. This is our fancy word of saying aim for a hypotonic urine. That's our fancy way of saying drink lots of water. You want to be aiming for a dilute urine all the time. People often ask, how much water should I drink? Our general recommendation would be on the order of, say, 3 liters a day. But I always tell people what's more important than the amount is that you're avoiding times where you're really concentrating. Meaning, let's say you go to work and you drink nothing all day, come home and have your 3 liters in a day, you haven't done yourself any favors. That time when it was really highly concentrated is when things are happening. So I love this term where it says aim for hypotonic urine, or the guidance we give people is, when you've drank a lot of water and you have a nice clearish urine coming through, you kind of want to be seeing that most of the time. If you start to seeing darker yellow, it means it's time to drink more water. And it's kind of a nice visual guide for you to see there. This one is good. It's actually changing in a lot of areas of kidney disease where it says aim for adequate protein intake. We used to always restrict people's protein, and that comes from older data with people with more advanced kidney disease where you want to limit their protein. But we know actually, especially when we're talking younger, healthy people, that actually having enough to keep your muscle mass and do that is an important thing. You just don't want to have very high amounts. So this is saying basically a normal protein type of a diet, and that's been liberalized. And then there's a few other items that talk about specific choices. I specifically want to point out, sorry, this is more of our shameless plugs. We have some more resources that specifically take you through that there on our website. One of the things I specifically want to point out that's come out a lot lately is people ask about either ketogenic diets or various supplements that combine ketones or ketones and citric acid. And I'm mentioning this because some of you may have seen it. There's commercial products available that are being promoted for this. What I'd say about that is the evidence is still not there, meaning there's trials going on right now. I know that some of the groups that sell this will point to some smaller trials, but there's much larger ones going on that I think will more definitively answer this question. So I'd say, we'll know more about that for sure soon. And this is what they said in that group too. There's not enough evidence yet for us to tell everybody to go ahead and do this, but we'll see what comes. The way I tell people is that there's not enough evidence yet to tell someone, so I can't tell all my patients, oh, this will help protect your kidneys. But if this is something that you want to do, as of right now, there's no evidence of harm, and it's something that, to feel free and go ahead and do. The one mention I make about ketogenic diets is that a lot of the times what you hear people talking about with a ketogenic diet is not actually that. Meaning a lot of the ketogenic diets that you'll hear people talking about, oh, I'm keto, they're actually just talking about a high protein diet, which that's not a true ketogenic diet. A true ketogenic diet is that you take the same amount of protein and you've essentially, or this is simplifying it, but you've essentially swapped your carbohydrates and fats. So it's actually a low carbohydrate, higher fat diet, and the protein still is more or less the same. I mentioned that's because a high protein diet is not something you want to be doing with polycystic disease. You want to have a normal protein diet, but not a very high protein diet. And a lot of what you see out there on Instagram and these fitness people and stuff like that, it's essentially a high protein diet. So if you're going to do a ketogenic diet, you need to do it properly, and this is where dietitians can be helpful as well. So I'll pause there because that question comes up all the time. It's not that I'm saying that it's bad or anything. It's that right now we don't have enough to say everyone should be doing this. We should hopefully have that information within the next couple of years once proper trials have been done. Great, okay. I knew we had a slide somewhere about the exercise, so this is what came up earlier in the question. So yeah, as I said, really this is the only thing I tell, or I don't even limit people, I caution people about this in terms of exercise and saying it's the high impact things that you want to avoid. Again, I've had football players, I've had lacrosse players come through and they've definitely carried on with doing their thing. They know they're at a risk that a high impact might actually cause one of the cysts to rupture, which can be an unpleasant thing. It's not like it's a fatal thing or anything like that. It could be an unpleasant thing, and then, they can make an informed decision about what they want to do. For the general person on the street, general cardiovascular activity, general resistance training and weight training is fine. If people are bodybuilder type level, squatting 500 pounds, maybe that might also put you at risk, you know what I mean? But to actually put enough pressure to specifically cause damage is actually kind of hard. People will notice as they exercise, sometimes the cyst might rupture, but as I said before, if you're going for a jog and a cyst ruptures, it was gonna happen. You know, it might happen the next day when you were just sitting in a chair regardless. It was probably on the verge of doing that regardless. And keeping yourself active is an important thing, right? So we don't want people to feel like they can't go out and exercise because they have these cysts. Water, we talked about this a little bit already. I'd leave this when I put the other slide in, but I think this is the main point, more so than the water, is rather than thinking about a number, think about you want to be drinking all day long, so go ahead and go get yourself, you know, water bottle technology has come a long way in the last few years. You can get those 2-liter water bottles that keep it cold all day long, right? Go invest in one of those. I tell people, in addition to having the urine as a visual reminder, it's a good idea to have a nice big water bottle that you fill up, put it in the fridge the night before, and you've got that visual reminder that I need to empty this out by the end of the day. I need to get through this. Having these little cues for yourself is an important way to think about it. And yeah, it helps with both your kidneys and some of the complications, things like stones and infections. Okay, so this is a big part of living well. So we talked about the diet stuff, unless there's any other questions there. Great. Pain. So this is, I think, one of the biggest things about living and managing polycystic disease. And there's a whole lot of different reasons why people might have pain. And I'm going to show you a different slide to break it down in a second. There's some of those more dramatic things we talked about, like a rupture or an infection or a stone. But then it's also just the size of the kidneys themselves can start to do a few things. They can cause symptoms just related to the fullness. In a lot of people, one of the common things, for example, is back pain. And you know, if in people with really large kidneys, it might actually shift off the alignment of your spine and can actually cause some problems there, right? So it can actually kind of throw everything off. My crude description I tell people is there's only so much real estate in there. And if the kidneys are or the liver are taking up a lot of that real estate, everything else gets pushed off to the side and you can start causing, you know, symptoms elsewhere, right? So there's a whole lot of different reasons that people can go through. Now, the management part I'm going to come to a second because we're able to add some more slides. So again, this is a great one that came out just towards the end of last year. And sorry if this is kind of slow, but this is another one of these amazing patient-led research that happened out of the States, where they basically came up with a way to classify pain in polycystic disease. And this put into words what I think a lot of us had been seeing, you know, in our clinics for a very long time. So they basically talk about 3 different types of pain. And I think this is pretty accurate. You've got kind of a dull, chronic, or a dull, long-term, achy kind of a pain. You've got a bang, sudden, sharp pain. And then not pain per se, but fullness. And we break it into those 3 categories. And then we talk about, for each one of those, what they came up with is to classify it based on how bad is it and how much does it interfere with your life. Because those are the 2 things that are going to determine the impact. So there's the pain itself, but how is it impacting you? And these are both things that we want to be looking at. And this is the way we kind of are assessing pain right now. It's nice, those 3 categories, because it kind of maps with the different reasons people might have pain. So I say, you know, maybe it's the wrong word because I'm not the one going through it, but I say this is the easiest one. And what I mean by this is the easiest one, the sharp kidney pain, is it's kind of clear what's going on there. Those are your acute episodes where, you know, bang, you've had a cyst rupture or you've got a kidney stone. Really bad, sudden pain, get yourself in to go get checked out right away type of a thing. And that's why I say it's not easy because obviously you have to go through with it, but we know what that is, and that's one that actually we can manage pretty well. Getting somebody through a pain episode when they've had a cyst rupture is actually a pretty manageable thing. Get yourself in to go get checked out, and you know, we can do acute pain management. The other ones are actually harder. They're harder because they're harder to find strategies. When we're talking about the chronic pain, a lot of it actually comes down to what we call chronic pain management strategies, meaning that, you know, it's unfortunately not something we're going to be able to take away when you have this longer term pain from kind of the discomfort, the size of the kidneys. It's something that we talk about, how do we manage, how do we live with this? We've got some resources, I'll show that on the next slide to talk about that, but a lot of it's going to be chronic pain management strategies. This last one, the fullness, we actually have some treatments that we can do there. So this is where people get to the point where, to give you the extremes, You know, I've got patients who are losing weight because they just literally can't eat enough. They can't get enough food in because they're so full and refluxing and throwing up all the time that they literally can't get their nutrition in. People feel short of breath because their kidneys are actually pushing to the point that their diaphragm and their lungs can't expand properly. Like, that's where we actually have some strategies where we can do some interventions, where we can actually take some of that out. It's invasive stuff, but we kind of keep that for that end of the spectrum, so that pretty advanced thing, because the treatments are, you know, we're talking about surgical or interventional procedures. But yeah, that middle one, it comes to chronic pain management strategies, and I'd say this is the more common one and the trickiest one. Thankfully, we do have some good resources available to it. You know, there's another set of ones that we developed along with the foundation here, where we talk about management, and there's some good chronic pain management strategies in there. One of the most effective things that we talk about in there is also pain journaling. And why I showed that last study is because I love the way it outlines it, which is probably the best possible way you could also do your pain journaling. And that's in our resource there, where we talk about, okay, what type of pain was it? How did it impact you? What did you do to make it better? What seems to make it worse? And it kind of, you teach yourself and learn, how do I manage and work with this? We could do a whole lot about this, and in fact we will. This is kind of a shameless, another plug in our talk here, is that PKD Summit that you just heard about. I'll be giving a whole talk just about pain in polycystic disease. But that's kind of it in a nutshell. I'll maybe stop there if there's any questions. All right, yeah, yes. Yes.
It's not related to a cyst rupture. Oh, thank you. That's not related to a cyst rupture or kidney stones. Have you encountered that? That's in the abdominal region, not in the flanks?
Yeah, so I mean, it is. There are other reasons that polycystic kidneys can cause pain. People with polycystic kidney disease can also have other things going on that are causing pain. So it can be both things. And that's why I say, you know, some of the resources talk about this, but maybe we'll go over it in a nutshell. If we're talking about sudden, severe pain that you can't manage, that's one of the reasons that we say, okay, go get yourself checked out in emergency. Yeah, if it's a cyst rupture, you know, it's basically we kind of bridge people through. I've got patients who have had so many cyst ruptures that they learn how to ride it out at home. They say, oh yeah, there's another one. You know, I'll keep my water nearby. Sometimes I'll send them a prescription for the pain, but they've learned, they know how to manage it. But if you're to the point where you can't manage it at home, or it's that severe, this is actually one of the reasons we say go and get it checked out, because actually it could be something entirely different. You know, someone can have polycystic disease and they can have appendicitis, right? If you've got pain that's doubling you over, this is one of the reasons you just need to go get checked out to make sure it's not something else. I kept using those examples though, because those are the common reasons, especially the cyst rupture. That's the really common reason for bang, out of nowhere, sudden severe pain. But yeah, since there are other possibilities that you need to get checked out if that happens. Yeah. Yes?
I've been to the ER a couple of times with the pain, and as soon as they do a scan and see the kidneys, they just go, and they start looking for anything else. So that's always a bit of a concern,
Yeah.
that as soon as they see something that it could be, they stop looking for anything else, and that's a concern.
It comes up, you know, to be honest, and one of the other items that people sometimes say is, well, I go in and they don't really know what to do with this. I know more about polycystic disease than they do, you know, and it might be true, right? But I'm not to talk badly about anybody, but to that, you know, emergency room physician, this might be one time in 20 years that they've seen polycystic disease, right? Because it's common to me as a kidney specialist, but very uncommon to them. What I always tell people is that at the very least, if they do that scan and they say, oh, it's just cystic kidneys, any of the other big bad things I mentioned, like appendicitis or something else, are pretty apparent as well. So at least we know, okay, at least we haven't missed anything else worrisome. Even if you get the kind of brush off there, that's the way I would spin it into the positive light, is to say, well, at least we know, okay, there wasn't something else we would have to do something differently about. But you're right, it sometimes happens, or I've had, you know, to be honest here, I've had patients say that they're being told, oh, they're just coming in because they want, you know, drugs, they want painkillers. It's like, you know, if you've got a kidney the size of a football and one of the cysts ruptured, you're not just looking for medications. You know, this is a real thing. I would like to think that doesn't happen, but and I know it does sometimes. It's unfortunate. And this is why sometimes, after that happens, we say, oh, just check in with your kidney team, right? Give them a call the next day, and then we can look at the scans too. We can kind of walk you through what's going on. Great. Oh, okay, there we go. So, we're going in sections now. We're talking about living well. Now we're talking about some treatment options. We're doing okay for time? Yeah, okay. I'll just talk all night long, so pull me off if we need to go, But so let's talk about treatment options. So I love this. I keep referencing this group out of the Mayo, Dr. Shabib. They're doing a lot of just fantastic work down there. Been lucky enough to have him come talk with us in BC a few times. But I love this. It's a few years old now. What is the number? Oh, 2018. Geez, I'm losing track of time here. That's 5 years now. But this is the way that we manage PKD now. And I'll take you through this a little bit because it is very different than what used to happen, say, a generation ago, right? I definitely have patients that, they're in the older generation, or say their father or mother, they would say, well, they went to see a kidney doctor. All they ever did was check their blood pressure and say, okay, we'll get you ready for dialysis or a transplant when the time comes. And that, unfortunately, that was it because there wasn't much else to offer. Whereas now it's just a world of difference. So this is the series of steps that we go through. We've already talked about some of it. So one is, okay, I see some cysts. I want to make sure this is actually PKD. Okay, so we've talked about that already. Then the next thing we do is we call prognosticate your renal outcome, meaning predict what's going to happen to the person in front of you. I was talking a lot at the beginning about how there's so much variability. So step 2 is actually to say, okay, what do I expect for this person right across from me? What do I see coming over the years? And then based on that, we select some treatment options. And what the nutshell is that for people who are predicted to have a slower form of the disease, we have some general measures that we apply to everybody. And then for people whose disease is more aggressive, we have some specific extra things that we add on top. So we now have this stepwise thing that we go through. We assess, we predict what's going to happen, and then we put the right treatment options in place. This box here, we've already talked about a lot of it when we say the basic optimized management. All the dietary stuff we just talked about, blood pressure management, make sure we're up to date on our screening and testing. So that's stuff that happens for everybody. Then there are some extra strategies if people are progressing more rapidly. So how do we predict if somebody's progressing rapidly? I put this picture up because some of you may have seen it. I might even just ask as a show of hands whose kidney doctor has shown them this exact picture before. I see a few. Yeah, good, I'm glad. I think you should be seeing this. I like to show this to my patients and turn the screen around. So what this is this is how we actually categorize polycystic disease. This is just a graph. It's just pictures. But to go into it a little bit more detail is, remember at the beginning I was saying, well, yeah, you could look at somebody's kidney function, but for most of the disease, it's not going to change. When somebody's kidney function starts going down, we're no longer predicting. We're seeing kidney function go down. I want to know what's going to happen before then. Decades, if possible, I want to know what's going to happen before then. So the way we do this, the gold standard, as we call it in medicine, the best way to do it is to assess their kidney size. So remember at the beginning, I was saying that as your kidneys develop more of those cysts and the cysts get bigger, your kidneys actually grow in size. We've learned over the years, and this is now over 10 years now that we've had this, that what you can do is you can actually very accurately measure just how big somebody's kidneys are, and you can see how fast is it growing. Meaning, I'll use this example of this picture that I was saying. So this dot, what this shows is this individual here at 40 years old, they had their kidney size measured, okay? And we have their size, but we also have their age. Why that's important is it's not just the size that's important, it's how fast you got there. So having their age tells us a speed. Those of you who remember your high school physics, distance and time, we have velocity now. We know how fast are the kidneys growing. And that's what's important. Because what this classification is just looking at everybody, all the possibilities of polycystic disease, saying how big is the kidney, how long did it take to get there? Because this individual is 40 years old, and you can see they fall in this red group, which you can imagine means they're going faster. That's why it's red. But, if they were in their 70s, actually, they'd be in one of the green groups. So, in other words, if somebody took 70 years to get to the same place that a different person got in 40 years, that 70-year-old is actually much better off because it's going much more slowly. So this, it seems like a very simple concept when I say it that way. You know, big kidneys at a young age is a rapid progressor, whereas smaller and as you get older is a more slowly progressing person. But this was a revolutionary tool that let us actually predict very accurately what happens with people. What this shows, and this is just evidence from the trials where they initially did this, is these same categories, you know, red, orange, down to green, directly go along with what's going to happen to somebody as the years go on. So with even a single scan, we can quite accurately predict up to 10 years. Our prediction is very good. Beyond that, you know, we sometimes becomes a little bit of what we call crystal ball gazing, because it's hard to predict very far in the future. But with one scan, we can almost map out what someone's life is going to look like. Sometimes we might even do multiple times, and then it gets even stronger, our ability to do that. So this is the tool that lets us predict what's going to happen down the road. And this has completely changed the way that we manage polycystic disease. So it's now considered standard of care that you would get some assessment, and it can be an ultrasound or an MRI, whatever tool is appropriate. Your kidney doctor will decide that, but some assessment of your kidney size. There's other pieces of information that'll help. You know, the genetics, why we don't do that in everybody is actually compared to your kidney size, it doesn't add much more. The kidney size is actually a stronger predictor than your genetics for those reasons I showed you with those families doing very differently. This is telling you for the individual in front of you what's happening. So that's why it's a better result. But if we have those results, we'll use them. Excuse me. And there's a few other clinical things that we might tell. But the biggest thing is actually this assessment of kidney size. And so that's actually built into this. When we're talking about this Mayo class, whenever you hear us use that term, or if you've seen that in talks, we're talking about that assessment of kidney size. And so we're saying people who fall in those higher up groups, the yellow, orange, and red groups, they're the ones who are progressing more rapidly, and we're going to want to be more aggressive with their treatment, as opposed to somebody who's in that slower group, they're progressing less quickly. So I'll start with a few of the management things for everybody. So again, for everybody, high blood pressure needs to be treated. I think that sounds like an obvious statement, but you'll hear us talk as kidney doctors about if you have cysts in your kidneys, we might actually even use what we call an aggressive blood pressure target, so lower than where we would get most people to, because that has also specifically been shown to slow down the rate of progression. And when I say lower, for example, we would say that in most people with kidney disease, we're aiming for less than 120/80, kind of a normalish blood pressure. There are some good studies that actually pushing that to below 110, so lower than we would ever get most people, actually slows down the growth of cysts in the kidneys. Now, that's a low blood pressure, so not everybody can tolerate that. You know, I remember one of the first times I was talking to a patient about this, he said, "No way, I'm not doing that, no way in hell." You know, I said, "Oh, okay, so what's the reason for this?" And he told me, "Well, you know, I work in construction, welding together sky rises. Like, if I get dizzy or lightheaded up there, things are not going to go well." It's like, okay, that's a fair statement, you know, so this is not for everybody, because that's the main side effect if we push too low, is you're going to get lightheaded or dizzy. Fair enough. I don't want anybody falling off a building. You know, I use it as a joke, but, you know, not everybody can tolerate that. Some people will get down to a low blood pressure and feel fine. Other people feel lightheaded and woozy and weak, and then, of course, we would back off. But your kidney doctor might talk to you about trying an aggressive blood pressure target. If you are doing that, my plug there is I think that's the type of person who really needs to be monitoring their blood pressure closely at home too, because you really want to have a good handle on it, not just being checked when you go to see your doctor if you're doing that aggressive target. And then we have different medications that we use for this. I think I have it on I didn't have it on the next slide. You know, there's a commonly used group of pills. There are some that we might actually talk about avoiding, but, you know, actually the options are pretty open. We have lots of different options available to us. And it can be quite common, especially as the disease goes on, that you might need more than one medication. That's quite common, especially as years go on. I had this plug, right? So we have this also available up on our website, a whole guide to monitoring your blood pressure at home. I think, you know, this being a lifelong condition, I tell everybody, just go and invest in a machine. So just one second. The one plug I want to say before I say that is all the machines that you can find out there, they're quite good. They're quite accurate. We actually have on our website, there's a little logo that you look for that says it's been certified by the CCS, and they're all good, meaning if you go to some of these stores, they might try to sell you the Bluetooth one that costs $300 and directly goes to your phone. It is no more accurate than the $40 one you get at Costco. That one's quite good. So I just caution people, don't get ripped off when you're buying a machine, and just, yeah, buy one. This is going to be something you do for the rest of your life. So it's probably a good thing to have.
I just wanted to add that through the Kidney Foundation, you can get them covered. And it's very easy to do it. So if you talk to, especially at St. Paul's Hospital at least, the clinic there, they can write a piece of paper and get you a free one.
Absolutely. That's a good plug. It's almost like if somebody was linked in with the Kidney Foundation, that would be good to know. But yeah, absolutely. And that's not just at St. Paul's. This is actually across BC. So yeah, absolutely. If that's a barrier to you, talk to your kidney doctor. So thank you. That's an excellent point. Yeah. It's amazing. We're so fortunate. There's been hundreds at this point, hundreds now that have been given out by the Kidney Foundation. So yeah, absolutely. Don't let that be a barrier. So it's always hard to bring up, but mention it to your kidney team, right? And there are options. Nobody wants to feel like they're being a burden, but this is well worth that investment for the health benefits it gives people. Yeah. Yeah. I should put that on for the next one. And then, yeah, there's some guidance about how to properly do it, because in addition to having the monitor, you need to make sure that you're doing it kind of in the right way. And so this is our little one-pager. Again, it's up on our website. You can print that off, and it just goes through the basics of how to do your blood pressure monitoring. I don't think I'll go through this in a lot of detail. I put this here mainly as a resource if people are going to look at this later. Just talks about the different types of blood pressure medications that you might see. You can kind of pick off, whatever is on the list of the ones you're on. But yeah, I don't think I'll go through this in a lot of detail. This just shows all the various blood pressure medications. Okay, so those are the things we do for everybody. I think at this point, a lot of people are aware. We also have specific treatments that we implement for some people. And this is now getting into that group of people where I say for more rapidly progressing patients. So there is a medication out there called tolvaptan. And I think probably a lot of people, I see a lot of nodding of heads, have heard about this. So what this does is it blocks a hormone that specifically gets detected in your kidneys, something called vasopressin. And by doing that, slows down the growth of cysts in your kidney and ultimately can delay the progression of your kidney dysfunction. I say slows down, that's a very important term because it doesn't stop it. When I talk to my patients about this, I very specifically say it's not a cure. It does not stop the process. It puts the brakes on it. It does that over the long term. In general, what the studies have shown us is that it slows it down on the order of 15 to 20%, meaning that for every 4 to 5 years you're taking this medication, you'll get another additional year of good kidney function. I like to put it that way because when I say it like that, you can see this is a long-term thing. It's not something that you do for 1 year and then it changes everything. This is something that we do ideally early on, which is why we need that ability to predict early on before a lot of damage has happened, and then it carries through. The other analogy I use, it's like making an investment, right? If you make an investment and keep it in there for 6 months, you're probably not going to make a whole lot there. Any benefit you might see is over the long term. So this is a long-term treatment strategy to slow that down, put the brakes on the growth. It comes though, oh yes, please.
Blocks vasopressin as well.
Right.
Has there been any studies or information that you can give with regards to the difference between taking tolvaptan and or just drinking more water?
Yeah, that's a really good question. So maybe to repeat it for the recording is, since this blocks a hormone system that has to do with water, which I was going to mention in a second here, is can you get the same effect by just drinking lots of water? And that's a really good question. And the short answer is no. And what I mean by that is even in all the studies that they did for tolvaptan, to do it in what they call a blinded way, meaning when we do a study, we don't want people to know whether they got the drug or what we call a placebo, if they didn't get the treatment. They told everybody to drink, as much water as they can, always be maintaining that pale urine. And in the studies, the people who weren't even taking a tolvaptan actually were getting well into that 3+ liter per day range. And despite that, we saw the benefits of this drug. So in other words, the trials basically already kind of compared to a group of people who were drinking lots of water. and it was additional benefit beyond that. And I think that the short answer is to drink enough water to completely shut that off is very, very difficult to do. Most people feel unwell. And we'll talk about this actually right now. Why don't we talk about to lead into this? One of the side effects of this is because the way it does this, there's no free lunch. So the main side effect of this medication is what we call the aquaretic symptoms. So by blocking that hormone, what it actually does, in addition to slowing down the growth of the cysts, the reason that hormone system is there in your kidneys is to regulate your water balance. And so by blocking it, what it does is it makes it so that you're always basically peeing as dilute of a urine as you can. You're basically peeing almost what we call free water. So a very, very watery urine output. On the order of average is actually 4 to 5 liters. I have some patients who get into the 7 to 8 liter per day range. So we're talking about a lot of urine output. Because of that, you also get thirsty, so you're drinking a lot, which for someone who's not been on the medication, they find it almost unbelievable that somebody could drink that much water. But this is, I think, one of the differences is for somebody who's on this medication, what's happening is you're first peeing out the water, so you're then really thirsty to replace that water. So all of the patients I have, they say drinking is not the problem, as long as they've got a water bottle nearby, because you feel thirsty, you actually enjoy it. Whereas if you're kind of forcing yourself to drink 5 liters a day, you would just feel sick all the time. You'd feel nauseated and things like that. So, but it's the urination that's actually, to be honest, the biggest limiting symptom of this. It's the biggest thing that I talk to my patients about before they go through this, is to think about, is this something that they could work into their lives, mainly being able to get to the washroom. The way it's dosed so that it's kind of a stacked thing, meaning early in the day you get a bigger dose, later in the day you get a smaller dose, and that's kind of intentional because just to try to get it to wear off by nighttime, really, because in a perfect world it would be on 24 hours a day, but then people would be up all night long urinating just as frequently, right? So, and that's kind of the biggest thing that limits people. So it's meant to taper off, but in that early part of the day, I tell people, you know what, it might even be every 30 to 45 minutes for the first part of the day that you're needing to go to the washroom. And so thinking about, if that's something that's workable. Again, it's different for different people, and we definitely have strategies to work with this. In BC, which is similar to the rest of Canada, our rates are about at 1 year, more than 90% of people are able to stay on the medication. Things go down as time goes on, but telling you that even though we talk about all this, the vast majority of people are able to work this into their lifestyle. It does take a lifestyle change. So this is one of the downsides of it. The other downside is that in the initial studies that they did for this, they found that up to, it depends on the study you say, that should actually say 4 to 7% of people will have a change in some of their liver tests when they do this. So, and that's something that we can't really predict, meaning think of it almost like an allergy. We don't know who it's going to happen to. It's just something that happens to some percentage of people. What we do to get around this is that for the first year and a half somebody's on this medication, they have to have blood tests done once a month to make sure that they're not one of those people. If they are, all we do is stop the medication and it goes away, meaning there's no permanent liver damage or anything like that. In BC, we're now north of in Canada, we're north of 3,000 patients are on this medication. Worldwide, this is in the tens of thousands. It's been around for over 11 years now in some places. With this monitoring system, 0 people, since this has been in place, have ever had any bad or permanent liver damage. So I look at this as, I tell all my patients, this is more of a nuisance, but with this, it's perfectly safe. Because if we see it, stop the drug, no harm done. But it does mean that for the first year and a half, you're going once a month for blood tests. So because of this, because it comes with those downsides, the term I use is this is a medication that comes with some baggage, right? If it's like a blood pressure pill, for example, often very well tolerated, few side effects. If it was like that, we'd be giving it to everybody. But because of those side effects, when we're identifying who is going to be taking this drug, we're really just keeping it for the people who are progressing more quickly. And this sometimes can be a little bit tricky because someone might say, oh, well, I know my brother is taking this. How come I'm not on the medication? And the way I like to put it is that let's think back to those families, right, where we saw the very difference in outcome. Well, if you're going to be like that person who makes it to 85 or 90 years old and never needs dialysis or a transplant, the last thing I want to do as a doctor is give you a medication that's going to give you a lot of side effects for the next 50 years of your life, and actually you would have been fine without it. So that's the reason that we don't use it. It's not that we're not trying to, treat people. It's actually because of the symptoms it comes with. We really want to say, okay, is the trade-off there? Is the benefit worth those downsides? So that's why we do that assessment, and we're keeping it more for the people who are more rapidly progressing. As more treatments come along, if they don't have that side effect profile, we'll use it in everybody, right? But it's because of that's why we're quite selective. So if you've talked with your kidney doctor and they said, you know what, maybe they don't think this is for you, this is probably the reason. This is actually what they're thinking is, you know what, I don't want to expose you to these side effects if it looks like you're doing okay without it. Yeah, so I'll maybe pause there if there's any questions about this medication. Great. Otherwise, we have a few other complications here that we talk about with that are outside of just the kidney, right? So we already talked about a lot of these pain ones, and there's some kidney-related ones, but there are other non-kidney items. This being a genetic condition, it's actually in every cell of your body, right? We talk mostly about the kidney and then the liver. We talk mostly about those two things, but actually every cell in your body has this gene change, and because of that, there are various other things that it can come up in. I'll talk through a few of the big items here. So the liver is probably the second after the kidney. It's very common for people with polycystic disease to have cysts in their liver, meaning you see the number there that I have 80% or more will have some degree of cysts. It's much less common that will get to the point that it causes a lot of problems like a liver issues where people need a liver transplant or something like that. So that happens in a minority of people, but when it does happen, it's a real big problem. So in other words, it's kind of like most people will have some amount of cysts. You'll get a small number of people who it really seriously affects their liver, but for those people, it tends to be the most dominant thing. There are some risk factors there. It actually tends to happen more in women than in men, and that just happens to be because estrogen specifically can also play a role in cyst growth in the liver, not in the kidney, but in the liver. This is one of the reasons that for my female patients who might be using oral contraceptives, I actually tell them you want to be on a non-estrogen containing one. We're a little bit cautious about things like hormone replacement. In people who have these liver cysts. There are other options available, right? But it's something that if you weren't aware of it, you might not know that difference. But yeah, so anyway, so in most people, it's not a big thing, but in some people, it can be a dramatic thing. As of right now, we don't have a lot of changes that we can, medication changes or things like that, but this is evolving. Actually, this is an exciting time for the liver disease too, because there's a group of medication that's being studied that's showing some promise. And I think before long, you're going to see, just like we do that measurement of the kidneys and predict what's going to happen, before long, you're going to see us doing that with the liver as well. And being able to predict who is going to have bad liver outcomes and how might we treat them differently. For those small group of people who have significant liver issues, this is definitely where we get other specialists involved, right? We definitely get liver specialists involved in this situation because it's a whole different thing. That treatment of tolvaptan that I just talked about has no effect on the liver whatsoever. Its only effect is on the kidney. There are other treatments that we use, so this is where we definitely bring more other people into the loop here. So the take home there is, since it's common, but it's only a minority of people who end up in big problems with it, if your kidney doctor's told you, oh, you have cysts in your liver as well, it's worth just elaborating. Okay, are we talking a few? Are we talking a lot? How much expansion is there? Because it can be the difference between, oh yeah, there's 5 or 6 cysts, but this will never be a problem, to maybe this is a predominant thing. The other big one we talk about, I'm not sure, probably a lot of people here have had their doctors talk about screening for aneurysms. What an aneurysm is it's an abnormal blood vessel that can form. Think of it almost like a little, if you're blowing up a balloon and it's got a little weak part on it, you'll get a little bulge there, right? That's kind of what an aneurysm is. It's a weak part in a blood vessel that actually starts to expand. Now, there would be mostly, I should say almost exclusively asymptomatic. Almost nobody would feel anything. This looks like a big picture, but when we're talking about these, we're talking literally millimeters. So, it's a small change, but where we really care about this is this can happen in blood vessels, for example, in the brain. Now, in the general population, so people without polycystic kidney disease, it's on the order of 1% or less of people might have an aneurysm. So in other words, this just happens anyways. In all comers, so looking at anybody with polycystic disease, it's on the order of, depending on what study you look at, on the order of between 5 to 7%. If you come from a family where people have had aneurysms, it's north of 20%. So, putting this, and the last thing I should say is actually, the nice thing about this is, if we detect an aneurysm before it causes a problem, and by a problem I mean because it's got this weak wall, they can eventually rupture and bleed. If we catch it before then, these days there's actually pretty easy treatments that can kind of fix that. Back many decades ago, it would mean a big surgery to fix something like this, whereas now they can do something what we call endovascular, meaning from the inside they can actually just put a little coil and fix it. And it's a day procedure that is pretty minimally invasive, so it's actually fixable. So we talk about screening for this. Putting this all together, what we tell people is that if you come from a family where someone's had an aneurysm, you absolutely need to be tested for it, and actually you would get repeat testing through your life. So if you get one, even if it's negative, you would keep having it done, because having that 20% risk is a really huge thing. So that's an absolute reason for it. The guidelines are always wishy-washy about, who otherwise should have it if they don't come from a family background. I can tell you personally, and this is just my guidance, and this is what some of the guidelines would suggest, a similar thing, is I at least offer it to everybody. I think it's a good idea to have it done for most people, because of the fact that, the guidance that used to say, well, maybe you don't talk about it unless they've come from a family background, that was when we didn't have good treatment strategies for it and didn't really know what to do with them. Now there's not a lot of downside of having that information, as long as you know what to handle with it and how to treat it, and your kidney doctor should have it. So it's the type of thing I think that should be discussed with everybody. If you come from a family where someone's got an aneurysm, you absolutely need to get it done. If not, I honestly would still strongly suggest you get it done, but that can be an individual decision. Oh, sorry, thanks. Yeah, I just said screening. I just keep saying screening. So it's a scan. So it can either be done with a CT scan or an MRI scan. My preference, there's sometimes some difficulty accessing MRI, but that's gotten a lot better over the years, and my preference is actually for all of these things is for MRI. Mainly just because, with CT scans, it's like an X-ray. It's like a fancy X-ray. It comes with some radiation exposure, and although that can be minimized, an MRI doesn't have that at all. Meaning that especially if it's someone who's young, and I'm predicting, okay, you're going to have, 6 or 7 of these through the course of your life, then I lean towards MRI for that reason. Yeah. So one of the two tests. Yes. So if someone comes from the question was when would I start? So my practice, if someone comes from a family history, from a family who has a history of aneurysms, definitely as soon as I know they're getting one done, and then they're getting one basically every 5 years after that. If they don't, then I sometimes say, it doesn't tend to come up a lot very, very early. By the time I think someone's about 30, they should have had their first one done. The nice thing is, and the evidence here, it's kind of all just based on opinion. Like, we don't have good studies. You would need to follow people for 50 years to know exactly, to do a study on this. But what we do know is that once you've had one done, your chance then of, if it's negative, your chance then of having a test that will show all of a sudden aneurysm goes down. And it's kind of like each subsequent one you do that. So when people are younger, I tend to do it a little bit more frequently because there is more of a chance that it'll just come up. As people go on in life, say someone's 65 or 70, if they've had a negative one at that time, the chance they'll develop one afterwards is actually quite low. But when someone's younger, I actually do more of these because it might just be starting to form. Yeah. Is that a hand up? Oh, yeah, yes, yeah.
Is there still dye involved with those tests?
Good question. So the question was, is there still dye? Because, people have probably been told dye is hard on their kidneys. If you're having it done as a CT scan, yes. Now, if your kidney function is good, the dye is not too worrisome for the kidneys. But yeah, for a CT scan, yes. For an MRI scan, no. For the aneurysm, that's right. Yeah. Someone's having a party out there, it sounds like, right? Like, I don't know. A few other items that we talk about. So we talk about kidney stones is another common complication. One of the nice thing is a lot of those diet strategies. Oh, and maybe, sorry, to go into this a little bit more detail. The reason why you're more prone to having kidney stones when you have cysts is what a kidney stone is basically when any of those chemicals that are in your urine kind of concentrate and crystallize to make a stone. When you have cysts, you kind of have these little pockets of places in your kidney where things can kind of pool. Think of it almost like a little puddle can form, and then it concentrates in there, and then that's where a stone can form. So there's actually a physical reason why you're more prone to it. There are also some changes in the way that your kidneys handle chemicals when they have cysts that do this. So for a couple of reasons, it's actually you're predisposed to have kidney stones. And if it happens, they can be very painful and they're treatable. In terms of prevention, though, one of the nice things is a lot of those same diet things that we talked about actually also decrease your risk of stone. Namely, by far the biggest thing you can do to prevent stones is to drink lots of water, which we talked about as being important anyways, and a few of those other changes like avoiding highly processed foods and cutting salt also decrease stone risk. And then, so those are the big ones I wanted to talk about. There are other complications, and but those are a little bit less common, so I didn't go into the rest of them. Again, on the website, there's a lot of good testimonials about that. And I'll maybe pause here, because that was a big, big section where we covered a lot of different things, to see if there's any further questions. Again, these are all various discussion points if you have them, but any other questions, I'll take those as well.
You talked about kidney size being a key factor in measuring the progression of the disease.
Yep.
Do you find often that people have kidneys that are not overly big, but yet their GFR has dropped significantly? And how do you deal with that?
Good question. So I'll just repeat it just for the recording and everything. So the question was, we talked about kidney size as being a predictor of what happens. Do we ever see people where their kidneys aren't overly enlarged and they do progress? And the answer is yes. Now, what that often indicates to us, though, is there's something else going on. And the unfortunate thing, I'll give you an example. So you could have somebody who's got polycystic kidney disease but also has diabetes. Or you can have somebody who's got polycystic kidney disease and has regular high blood pressure, not just blood pressure from their kidneys. And the unfortunate thing about that is anytime you have multiple things affecting your kidney, it's kind of like one of these 2 + 2 = 5 situations, where the combination of items is actually much worse than any of them alone. So if you happen to have, say, polycystic disease, and maybe you're in one of those more slowly progressing groups, but you add on top of that diabetes with a lot of really high blood sugar, you're going to end up with kidney problems from the diabetes way faster than somebody else would. So the answer is, yeah, we sometimes see this, but it's often a clue that it's not just the polycystic disease going on, and it makes us start hunting for, oh, what else might be happening here? Yeah, it's a really good question.
Heart disease being maybe a complication, perhaps, or something that, can be exacerbated by PKD. Is there anything, screening-wise or, anything else that you recommend?
Yeah, absolutely. I didn't get into a lot of detail here. That's a really good question. And actually, that's not unique just to polycystic disease. All kidney diseases, people with any type of kidney disease are at higher risk of having heart disease as well. So anybody with kidney diseases, we should be doing a screen and making sure they're doing all the appropriate risk reduction things in terms of their heart. It's actually one of the other reasons that we try to be really aggressive with blood pressure as well in polycystic disease. The other way I describe this to people is, say you've got regular old high blood pressure, which most people develop, say, in their 40s, 50s, or even 60s, so a bit later in life. Let's say you're 50 years old when you develop high blood pressure. Now maybe you have 30, 35 years where that can cause consequences to your heart and blood vessels. If you have something like polycystic disease that's triggering your high blood pressure, and you've had high blood pressure since you're 20 years old, now all of a sudden that's got 60, 65 years where it might be having an impact. So it's one of actually the reasons that because these come up earlier, that we want to be even more aggressive with that risk reduction strategies. The nice thing though is it's a lot of the same stuff. It's blood pressure control, healthy diet, and then yeah, in a lot of people we will use medications as well, but that's also similar with other kidney diseases. But yes, very, very good point. Yeah, it's one of the reasons to, I think, be really aggressive about a lot of these lifestyle things. Whenever we talk about this in medicine, we talk about what are modifiable risk factors and what are non-modifiable risk factors. And by that I mean, what can you change and what can you not change? You can't change the genes, you can't change your genetics that you were given, but things like, yeah, maintaining a healthy weight, being on top of the blood pressure, those are things you can change. And when you have a lifelong thing, you want to be even stricter than the average person about that. You want to be right dialed in, and then that gives you the benefit over the rest of your life. Oh, sorry.
Is it a long time that they're going to keep supporting, or can they stop at any time, the company?
For, oh, sorry, I missed maybe the first part of the question.
The Janard,
Oh, okay, yes.
are they still committed to constantly for the next 5, 10 years and just not stop the trial? Or?
Yeah, so a couple things. The question is this going to be supported? And so first, I'll come to the last part of that question. I don't like the word trial, and I don't like the word, it's newish. We've had it now almost 10 years now. Sometimes I still get patients being sent to me that, the doctor's saying, oh, this is something experimental or something like that. That makes it sound like we're making you a guinea pig. It's not. It's well proven. It's been around almost 10 years now. In terms of the support, actually, we're very fortunate in BC. As of right now, we're the only province where this is actually covered and paid for. So it's actually, it's not provided by the company. We actually, the government in BC has been, kind enough to actually support that. So if you meet those criteria that we talked about, it's actually something that's covered so that we don't have to worry about it. Not that I trust the government with everything, but, they've done the right thing on this one. Oh, yes. Yes, but so the question was, are new medications or trials? Yes, I don't want to give any specific names just yet because I want to see how it plays out. But some of the most exciting, I would say, is there's a couple going on around what we call repurposing of drugs. This is a big thing in medicine now where we're taking old drugs that we used for other things and seeing, oh, might it work in a different disease? Why that's exciting is because some of these are drugs that we've had around for a long time, which means that we've got a lot of experience knowing what their safety is like. They're dirt cheap because they've been around for a long time. And some of the ones that are being trialed, I can tell you, have very few, if not almost no side effects. So I don't want to bet the farm yet until we know what's going on, but I think this is a really exciting time where over the next couple of years, you might see some other things come through. And they might be drugs that we've known about for a really long time, but we're now studying them for this exact reason. Yeah, so stay tuned. I think this is going to evolve. This is the other reason why I think everybody needs to be linked in with a kidney doctor if they've got polycystic disease, because things are going to change. And, you kind of want to know about it when one of these new treatments comes out.
So a question almost to the point on the last point there.
Yeah.
How will I know when I need dialysis or transplant?
Yeah.
And is there some criteria that we use in BC that determines that?
Yeah.
And can you explain a little bit about
Sure, we can go into that. And that was actually the last little section. I just want to check how we're doing time-wise, because we do have a little section about what we might do if the kidney function is going down. Okay, so because that was the one I was saying I would keep maybe, and maybe we wouldn't cover it, but maybe the long and short of it is that's something we kind of do when people are getting closer to that point, really determined by their kidney function. I often have people come in kind of earlier on, knowing that this is coming, saying, well, can I just get things going now, right? Meaning that, I've got my partner here who says, yeah, when the time comes, I'm going to donate a kidney to you. Can we just get the ball rolling now? Because I know this is coming, even if it's some years from now. And the reason that we wait until it's a little bit closer is there's a whole lot of testing that people need to go through, actually more so even for the donor rather than the person who's receiving the kidney. And so that needs to be done kind of closer to the time of. As a general rule of thumb, and I have the slides there which we'll send out, you can kind of read through it, but as a general rule of thumb, once people's GFR, their kidney function number, is getting down to kind of 20 and below, that's kind of when we start to think about this process with the mindset of it's something we actually move on when they're getting closer to 10. So that kind of builds in the time to do that. So again, another reason to be followed along is so that there's lots of lead time. You have lots of runway before that comes, and you can say, okay, time to start thinking about this. Yeah, we had a bit of a section here about this, but actually I'm glad we spent the time on the other stuff. We have good little webinars on our BC Renal website that if you have some more questions about the transplant process and what does that look like, we've got that all in detail up there. But yeah, that's a general rule of thumb, and that's the reason that we often tell people to wait. Because I definitely get that all the time in my clinic when people say, oh, well, can't we just get this going now and do the testing? It's like, well, if it's going to be 10 years from now, we'll need to do the testing a lot closer to the time of. But if you've got someone out there like that and you're early on and they're already offering, buy them a nice Christmas present every year, take them out to dinner every now and again. Never hurts to have that person, waiting in the wings. Yes. Of course.
Is the GFR still kind of the gold standard predictor? And how reliable?
You guys you can be up here with some of the questions you guys are asking. You're asking very, very well-informed questions. Yes and no. So it's so GFR, the question is the GFR the best predictor what's going to happen and when you're going to need to go on to things? When I say yes, is it still the test that tells us where is your kidney function at any point in time? But just like we're developing, ways of predicting what's going to happen early on with polycystic disease, there are more and more of this coming with kidney function itself as well. So there are other tools you might hear your doctor talking about. So the technical answer is there are other predictor tools on top of GFR, but for the here and now, that's really the one that we use as the rule of thumb once it's low when we're talking about these treatments. In polycystic disease, early on, it's all about kidney size and kidney progression. Later, once you're getting to the point where we're talking about, okay, when might we need to do a transplant and things like that, then that comes to GFR. It's a good question, though, because there are other tools being developed. So stay tuned. Otherwise, yeah, because there was a section there. Again, there are other resources. I'm glad we spent this time here. I don't know if there's any other questions or comments about any of the rest of the topics that we covered today, not just this treatment part.
What about, I know you had a little small section in there about ketocitrin, diabetes,
Yeah.
and a ketogenic diet. Do you have anything more that you can say about that?
So the question, just to repeat for the recording, is just coming back to some of the trade or proprietary things, supplements of either ketone plus or minus citrate or either of the two by themselves. I think what I would say, and my honest answer, is it looks quite promising, but it is this kind of smaller trials that have been done are not quite enough. It's not quite conclusive enough to say that this is something we should be doing for everybody. There are bigger trials going on right now, including one being led over in Toronto, which hopes to answer that question. And if that comes out that, yes, now we have definitive evidence, as we say, now we have actually clear proof that this is beneficial, then that's actually a relatively more straightforward thing. That would be the type of thing we could do for everybody, right, as opposed to a drug with a lot of side effects. So this is why when I have someone who's interested in it, I say, yeah, if this is something you're keen to do, I think that's reasonable. I hedge a little bit because I'm always, I think they're doing great work, getting this products out. I'm just always a little bit hesitant when a product comes before the data is actually there. And usually we do it the other way around, right? We want to see the data and then go to market with it. But we should know it within the next couple of years, and then we can comment. So yeah, that I think if people want to do it, I think it's okay. There's no harm to doing it. It's just there's not clear benefit. And then the whole ketone thing, the one point I really caution people is make sure you're not overdoing it on the protein if you're going to do it in a dietary fashion.
And can you, I know you're not commenting too much on it because they're not true studies.
Yeah.
When you're doing that, what is the range? Like if your kidney function is starting to drop dramatically and then introducing that type of thing, is there any comment on that?
Yeah, that's a good question. If you were doing a ketogenic diet, what about as your kidney function goes lower? It gets trickier because in lower kidney functions, that's where we start to limit protein specifically. And that's where I say, in the olden days, we used to do that in everybody because where the data actually came from is in people with lower kidney function. If you're looking for a rule of thumb, once you're down below about 30 or so, I start to get a little bit more nervous about the protein intakes. Yeah. And that's really what it is. It's the protein. Yeah. Yes?
Apologies if you've already spoken this,
No,
but
of course.
for people who were diagnosed at birth, at what point
Oh, that's a really good question. So the question being, if someone was diagnosed early on, when can we use all these tools? So those items that I talked about with kidney size and age and things like that, right now that's only in adults. And they're kind of working on it, but it's really difficult to do in children because the problem is children's kidneys grow, right? So this is all based on looking at the speed of somebody's kidney growth, but in kids, that would also depend on just their normal growth trajectory. What I didn't talk about, on the slides is those kidney size, it's also normalized for height. As you can imagine, someone my size is going to have smaller kidneys than someone who's 6.5 feet tall. And then, so already you need to adjust for height, but in kids, you have the variable of they grow at different rates to begin with. So that's why that doesn't really exist yet in kids. It's a much harder question to answer. Once they start to get those tools, we can start to use, even once somebody's 18. But it's tricky because, without getting too technical, a small inaccuracy in the scan could actually make a big difference, because if we're only talking about 20 milliliters of difference, putting them between categories, it can actually be trickier, whereas the later someone goes in life, it gets more and more accurate. Once you're into your mid-20s, though, or so, then it's very, very good. Yeah, it's a really good question. Yeah, this was the content I had, so that's why I just want to see if there's other questions, but I don't know if, no, did we? You're all tired of hearing me talk by now. I think that's fair. Yes.
Is there any proof that intermittent fasting decreases the size of the cyst?
Yeah, so the question about intermittent fasting and whether that specifically helps, not in and of itself. Now, the one way is where it can show to be benefit, and this is true about intermittent fasting in general, is that when people are in a negative caloric balance, and if they're carrying some extra weight especially, that's where it can be beneficial. The jury's still out about intermittent fasting, about whether there's any additional benefits as opposed to just that caloric balance as a good weight loss tool. I'm kind of in the camp, I think there probably are some, but there's no clear evidence of this. So when I come back to that part of saying maintaining a healthy weight, I wouldn't say any one tool for that is better than any others. It's really about what works best for you. There's certainly no harm in doing that, though. So some people do find it to be a very, very effective strategy for weight loss. And then, yeah, definitely, as long as people are keeping themselves well hydrated, I think that's a totally fair way to go. Great. Well, otherwise, I mean, we covered a lot of stuff. As I said, there's recording is being done, which is why I know it was bad sometimes moving away from the microphone, but hopefully picked it all up. Recording's being done. The slides will be there if you want to go through it at a later date. Otherwise, just thank you all for all the questions and discussions. It's so good to see such a great group out here and have all this discussion. So thanks for that.